Okay, so good afternoon, good evening, everyone. I'd like to thank the International Academy of Clinical Hematology for sponsoring this webinar series. My name's Dr. Christopher Hourigan. I work for the National Institutes of Health, and I'll be talking to you today just for 30 minutes, just to give you a high-yield overview of measurable residual disease and acute myeloid leukemia. I have some disclosures. I have the following relationships. I receive research funding from Celus and from Merck, and I have research collaborations with QIAGEN and Archer. I've served on advisory boards for Janssen and Novartis as part of my official duties here at the NIH, and I do paid part-time clinical work for Johns Hopkins. The disclaimer, I work as an NIH employee. I work for the US government. These are my personal opinions and do not reflect official positions of the US Department of Health and Human Services or the federal government. So the objective today, as I said, this is just going to be 30 minutes of a high-yield, clinically applicable factors for MRD and AML. So firstly, I wanted to outline the current clinical consensus guidelines for the use of MRD in AML. Secondly, discuss some opportunities and limitations afforded by next-generation sequencing, which many of you will be familiar with. And then summarize some recent experimental evidence regarding AML MRD that we presented just in June at EHA. So what is MRD? You know, this is something you would previously have referred to as minimal residual disease. I think there's now good consensus for those in the field that we should be talking about measurable residual disease, and this is something that a term that took off around 2014, and now is the accepted terminology for this. Before we go any further, I just to refer to the gold standard of a cytomorphological complete remission, just to say that gold standard isn't so gold. And one dirty secret we have is that there's actually quite large variation between skilled hematopathologists on how they'll call and quantitate blasts. This is data from last year from hematopathologists here at the NIH. I wasn't an author on this paper, but I believe these are my patients, where they asked pathologists to independently score the results of smears and biopsy samples from patients with AML. As you can see, this is a surprisingly large range between pathologists, and this is essentially the gold standard we're working with prior to the introduction of MRD. And so MRD is really predicated on the idea that if we use higher and higher sensitivity tools beyond the light microscope, we can get a better appreciation of disease burden. And so what I'm showing here is just a schematic and a highly stylized cartoon to show 3 patients treated with intense induction chemotherapy. Of every 4 patients treated, our expectation would be 3 of those would get a remission. And then the relapse events, early relapse, late relapse, and really trying to predict those relapses on the basis of pre-treatment factors can only help us so much. As we use higher and higher sensitivity tools, so if we go to microscopy or FISH, or chimerism in those post-transplant, we get a better appreciation of disease burden. As we go higher still, and we're going to talk about flow and gene expression PCR today, we see actually this early relapse isn't actually relapse at all. This is primary refractory molecular disease that has slipped below the CR threshold for a brief period. With higher and higher sensitivity tools, we get a better appreciation. We'll never have a perfect appreciation of disease burden because we're only sampling a smaller amount of the patient. But we can get a better idea of those clinical outcomes by having better sensitivity tools. And so why this is important is because it can help us with prognosis. So these are 2 independent studies. On your left is a study from here at the NIH using molecular methodology. On the right is a much larger study from the Fred Hutchinson using flow cytometry. Essentially, though, the take-home message from these 2 studies are the same. This was taking a pre-transplant sample prior to allogeneic transplant of patients with AML. And what you can see is in gray in both cases was any level of detectable leukemia. whether that was grossly evident active disease or whether it was at MRD level, was associated with poor outcomes post-transplant. The best responses were seen in blue for those who were in a CR and were MRD negative. And that seems consistent across studies. Just to take that one step further, in case you're not convinced, this was a meta-analysis the following year from the Fred Hutchinson group, looking across studies, and regardless of modality used, we see the same direction of effect and a similar effect size, that the presence of measurable residual disease in AML patients in CR before transplant was associated with worse leukemia-free and overall survival. And that seems to be a consistent trend across studies. So on the basis of a great deal of evidence like this, in 2017, the ELN updated the response criteria. And this was response criteria that had essentially been static since the mid-50s. And updated the response criteria to have this new category of a CR without minimal residual disease. So why did it take so long to update the response criteria? We already knew AML was a genetically heterogeneous disease on the basis of cytogenetics. I'm showing you here. The Cancer Genome Atlas studies in the past 10 years have really shown us that there's many different ways you can combine somatic mutations to make a leukemia. This is a Circos plot showing the combinations of somatic mutations that go together to make an AML. But even worse than that, this is a clonal disease. So the predominant genetic characteristics of leukemia at diagnosis may not be identical to those that are responsible for relapse and death. So there's evolution even within one patient over time. Last year, consensus recommendations resulting from over 2 years of discussions from 24 experts from 19 different institutions throughout Europe and the US were put together as under the auspices of the European Leukemia Network to define some consensus recommendations for how we should test for MRD and AML. I'll take you through those. So this slide summarizes that document, which is available to you in blood from last year. Summarizes in the most condensed way I can those recommendations. So essentially, if you have one of 5 targets, and that's mutated NPM1, present in about a quarter of AML cases. If you have a core binding factor leukemia, obviously if you have APL, and for those very rare cases of BCR-ABL Philly positive AML, so overall that probably covers 40% of AML cases. You should use molecular testing. If you have one of these pathognomonic markers and you have a validated qPCR assay, you should use that first. For all other cases, the recommendation for AML MRD monitoring is for flow cytometry. And we define some minimal expectations for what flow cytometry would look for. It's at least 8 colors using the same tubes at diagnosis and follow-up. The preference was for bone marrow, not blood, and collecting at least 500,000 events. We thought a 0.1% threshold was meaningful as a limit of detection. And for multi-center clinical trials, we really thought it was important to have central analysis. There's a fair amount of art in calling MRD by flow cytometry, unlike the case of molecular. And so we thought it was very important to have central analysis when there's multi-site studies. In terms of the time points one should measure, it was important to measure MRD at diagnosis to determine what would be a good marker to track. There's most evidence for after 2 cycles of chemotherapy, pre and post transplant, obviously, and then at the end of treatment, both in blood and bone marrow. For surveillance follow-up, we thought every 3 months for 24 months after the end of treatment was reasonable, given the usual kinetics of relapse in blood and bone marrow, or if the choice was to do blood alone, a more frequent interval of every 4 to 6 weeks. That's really based on the idea that for many of these markers, there's about a log increased sensitivity by looking in bone marrow than blood. And so if you were to choose to monitor by blood only, the recommendation is to monitor them much more frequently. There was broad consensus that all clinical trials going forward should have some kind of MRD assessment at times of evaluation of response. It's really, none of us thought it was reasonable to to design trials going forward without having a higher stringency assessment of response beyond cytomorphology. So these guidelines came out just over 18 months ago now, and have started to be adopted in routine clinical standard of care guidelines. To give you one example, this is the latest NCCN guidelines, which is a group of consensus criteria of cancer centers within the US, which has essentially adopted the recommendations of the ELN. They do make reference to next generation sequencing in these guidelines, and I'll come back to this point. So to summarize this first part, complete remission designed by cytomorphology and relapse are really artificial constructs. Our appreciation of residual disease burden is limited by the sensitivity of the tools we use and the samples we measure. AML MRD tests provide additional information for those in CR beyond current risk stratification using pre-treatment surrogates, and allow us to have better estimates of current disease burden post-treatment, allowing stratification into high and low risk of relapse. And then finally, the reason it took so long to change these response criteria was AML is not one cancer, so there was no reason why there would be one test to track MRD. The consensus currently is that qPCR for if you have a leukemia with one of those 5 situations, and for everyone else, flow cytometry. For those of you joining us late, there's a button with a question mark for those of you who want to answer questions. I'll also leave time at the end. So moving on, I wanted to discuss some of the opportunities and limitations associated with next generation sequencing for MRD AML assessment. Many of you will use next generation panels, so-called Myeloid panels, where you're looking for recurrently mutated genes seen in MDS and AML at diagnosis. So they're useful in some actionable genes, IDH1, IDH2, FLT3 ITD, but also give us typically much more information at diagnosis to try and get a sense of the biology of that clone. There's great interest in adopting this same technology, the same next generation sequencing technology to the tracking of measurable residual disease, but clinically we're just not there yet, and I'm going to explain to you why that is. So firstly, why NGS and AML MRD is appealing. So this is a New England Journal paper from 2006 from the UK group, from the MRC, from David Grimwade's group, looking at mutated NPM1. This is typically an insertion in exon 12. It's present in about a quarter of cases of AML, particularly normal karyotype AML. This is testing by qPCR, and these were ELN validated tests. What I'd like to show you here with the mouse is the ELN had put a great deal of work into validating approved tests for the most 3 common insertions in the exon 12 of NPM1, this A, B, and D. And as you can see, these account for the vast majority of patients. What you also see, however, is there is a long tail. And so there are patients who don't have one of those common mutations in NPM1. It's in the same region, but a different sequence, or a longer insertion. Using quantitative PCR, that would require establishment and validation of an individual assay for each one of those mutations. The appeal of next generation sequencing is it's possible to sequence this entire region, and you wouldn't have to have patient-specific assays for each of these possible insertions you see there. This is analogous to in the lymphoid malignancies, where now NGS has really revolutionized the tracking of minimal residual disease, where we don't need allele-specific PCR anymore because we have next-generation sequencing, which can track that mutated sequence. So potential advantages, you can, as we mentioned, you can capture multiple variants within one gene region in a single assay. You can also multiplex detection of many MRD targets within one test. And so you don't need to set up multiple assays for the different forms of AML. You know, this would allow validation of only one workflow and quicker translation to the clinic. And also, as next generation sequencing becomes more developed, the throughput is going to vastly exceed what's possible with conventional molecular testing with quantitative PCR or digital droplet PCR. So the limitations of next generation sequencing, however, are regards to the limited detection. So The limit of detection for an acceptable AML MRD test is at least 1 leukemia cell in 1,000 normal cells, well, 0.1%. But NGS, particularly looking for single nucleotide variations, which is a common form of mutation in AML, has an intrinsic error rate of 1 or 2%. It's predominantly library prep, but also just the machines themselves have an intrinsic error. And so that's obviously constrained if we want to look for very low-level disease. There's also been some concerns about the dynamic range of next-generation sequencing compared to qPCR, but I think that's increasingly less important. So the challenge of next-generation sequencing, and the reason I think why you don't see it in the ELN guidance so far, is can we get beyond this 1 or 2% error rate, which obviously would limit our limit of detection to only 1 in 50 or 1 in 100, inheriting these approaches to reliably detect MRD with similar sensitivity to these other modalities. There's huge advantages to using NGS, but this is a real limitation. There's many papers that have used a variety of approaches to measure MRD using NGS. My take on these is it's highly publishable, but it's not ready for prime-time clinical use yet. We've got a few constraints to get through. And so just to emphasize this point, next-generation sequencing is not currently part of the ELN International Consensus Guidelines. It made it onto some other guidelines at a national level, but it's and maybe a feature of future ELN guidelines as we have consensus on how best to use this technology. But many of the tests currently in use using NGS at diagnosis just aren't fit for purpose for tracking MRD. And we really actually need to set standards of how we're going to use these testing in a remission state. Some of the known issues are, we know AML is a clonal disease. There's evolution over time. And so you can have very commonly emergent and selection of subclones. The classic example of this is FLT3-ITD, where relapse may be with a subclone with some other activated tyrosine kinase. The error rate's intrinsic to most conventional NGS techniques we've discussed. There are error-corrected approaches, but there are caveats to adapting this to a clinical use so far. And there's false positive rates. And this is something that was an FDA guidance released last year addressing some of these issues, but we have some way to go before we can make NGS a clinical test. Our understanding of clonality may be limited by the amount of genetic material we put in. And again, these panels we run at diagnosis really aren't helpful in tracking MRD beyond that. And then lastly, we know that these mutations aren't the same as having a cancer. So mutated genes, for example, those associated with age-related clonal hematopoiesis or clonal hematopoiesis of indeterminate potential, very commonly DNMT3A, TET2, or XXL1, the so-called DTA genes, can be detected in healthy older people without hematological abnormalities and can persist in persons in long-term remission. And so there was nice work from Peter Vork and his group last year in the New England Journal saying that these three mutations may not be useful for tracking residual AML, even though they're commonly mutated in AML. And then finally, we need consensus uniform reporting standards, and I think that's likely to be some feature of the next iteration of the ELN guidance. And then finally, I wanted to give you some recent experimental evidence regarding the utility of AML MRD. I've already told you that it's prognostic at a cohort level when we can better risk stratify patients in remission for their post-transplant relapse and survival. But I wanted to give you some new evidence that we presented at EHA in June. And so there's been over 100 genes found to be recurrently mutated in AML and potentially trackable. We've talked about the error rates. This schematic from an article that will come out in British Journal of Hematology early next year just takes you through the possible outcomes from doing a NGS test. And so germline mutations will be in the range of 50%. The area we're most interested in, those variants less than 5%, is the area which is most error prone for conventional sequencing. So there's error correction approaches, and in broad categories, there's two forms of error correction approaches being used. One, a laboratory form, unique molecular indices or consensus clustering, and a second form, a bioinformatic form of background error modeling. The take home from these really is that there's many other factors which impact these tests. The take home from these, though, really from a clinical perspective, is it is possible to overcome some of these intrinsic constraints of NGS, and I think there's good hope that in the future we'll be able to use this as a tool to track residual disease. We've demonstrated this in a pilot study by taking the data from the Sanger, where they had sequenced over 1,500 AML patients at diagnosis with a broad gene panel. We picked a small cassette of genes to use for tracking MRD, and just picked a 13 gene panel where we thought would be able to predict, would cover about 79% of AML patients. And we used it to answer this really important question. I've shown you data that the presence of MRD prior to an allogeneic transplant is associated with poor outcomes, increased relapse, worse survival. We really want to know that, can we do something about this MRD as doctors? And so can changing the intervention change the clinical outcome? If you have a patient who's in remission and has MRD, can you do something about it? And so to test this, in 2011, the Blood and Bone Marrow Transplant Clinical Trials Network had done a trial comparing reduced intensity with myeloablative conditioning. This trial didn't have any MRD information. So what we did over the past year was take samples from patients who were treated on this trial and were randomized to one of the two arms, and assess them using next generation sequencing to see if we could see if increasing the conditioning intensity could have an impact on the outcomes. As I mentioned, this was the plenary at EHA this June, and the headline results are here. In those patients who had a detectable variant pre-transplant, randomization to reduced intensity versus myeloablative conditioning was associated with an increased relapse, and that was a hazard ratio of about 6, decreased disease-free survival, hazard ratio of about 3, and decreased overall survival, hazard ratio of about 2. That effect is even more pronounced when you remove the DTA variant, which I'm not showing you here. So just to summarize some final thoughts here, and the clinically useful take-homes. Where do we go now? So measurable residual disease is the disease left in the patient. The test result is limited by the small sample the patient evaluated. If we're drawing blood from the right arm and the leukemia cell that's going to be responsible for relapse is in the left leg, you're not going to track it with that test. So no MRD test, regardless of how sensitive it is, will predict every case of relapse when measured at just a single time point. So you should expect false negatives. Mutations or weird cells are not the same as having cancer. No MRD test is going to have perfect specificity for residual leukemia when measured at a single time point. So you should expect false positives. An MRD testing at a single landmark time point has a good ability to risk stratify patients in a cytomorphological remission at a cohort level, but is suboptimal for these reasons at an individual patient level. So, and this is the most important take home, analyzing trends in MRD testing is likely to be most informative. You shouldn't act on a single value. How are we going to proceed in clinical practice? If your patient has a molecular target, mutated NPM1, core binding factor, APL, all those rare cases with FILI positive, you can follow MRD using quantitative PCR. For all other cases, you should use flow cytometry. Next generation sequencing panels currently used at diagnosis are not fit for purpose for tracking AML MRD. There will be tests available with next generation sequencing, but they're not the tests you're currently using at diagnosis. In terms of time points, the consensus is you should test MRD at diagnosis after 2 cycles of chemotherapy and after the end of treatment in blood and marrow, follow up every 3 months in marrow and blood, or about monthly in blood alone. And then I think the one thing we all agree on is that we need more evidence on the utility of MRD testing and interventions on the basis of MRD, and that all clinical trials going forward should have high stringency assessment of response. I'm going to leave the last 5 minutes for questions. So I'll thank you there, and I'll take questions from you all. Thank you. Okay, so one question coming in. If I don't have PCR available, is it okay to use flow? So yeah, I think this is a common question. Your ability to measure MRD is going to be a function of what you have available in your local environment. I think if you have an expert in flow cytometry who's comfortable reporting out MRD for AML, which is more challenging than some other hemalignancies, I think it's very reasonable to use that in all cases if that's what you have available. We know in many situations molecular testing is not currently available for MRD tracking. It's sometimes available as a send-out test, but I think many people would say that measuring just by cytomorphology alone is going to be insufficient. So you should do the best you can. So if you can't order those molecular tests, then flow cytometry is the next best thing for those cases. The advantages of the molecular tests over flow are they're just highly reproducible and highly standardized. A lot of work went into standardizing those tests across multiple sites, and so there's good evidence using those standardized tests of what individual thresholds mean, and there's variation between expert flow cytometrists from center to center, and so that's the potential advantages of molecular and why we prioritize that over flow. Okay, any more questions? So again, sorry, the questions, there's a button with a question mark. You can type in your questions there. Okay, so another question coming in. What should I do with my patient who's MRD positive going into transplant? And so this is, again, a difficult question. We know that people who are in a complete remission by cytomorphology but are MRD positive have worse outcomes going into allogeneic transplant than those who are MRD negative. Having said that, we don't have good evidence that converting those people to MRD negative before transplant leads to better survival. There's many trials ongoing now with randomizing patients to intervention versus straight to transplant in the MRD positive state. And so I think my answer for now would be I'd enroll that person on a clinical trial of one of those randomization to intervention versus no intervention. We really need to answer that question of how we best use these tests for more than just prognosis. We have 1 more minute. Any more last questions? Okay, so I think that's it. So I'll oh, here we go. One more. Should genetic abnormalities and the presence absence of MRD be analyzed or assessed together? MRD in isolation, how informative is it? Okay, so this is talking about looking at pre-treatment surrogate disease biology, the FLT3, NPM1, cytogenetics, and how does that how should that be integrated with MRD? I think there's obviously still a role for stratifying. The European Leukemia Network still has risk categories pre-treatment. I think though once someone's completed treatment, the MRD or how much disease they have related to treatment is actually your ground truth of how the treatment worked. And in multivariate analysis, some of those pre-treatment surrogates of disease biology actually fall out in preference to MRD. So I think if you have a low-risk patient who still has detectable leukemia after treatment, that patient by definition is now a high-risk patient regardless of what the genetic test showed prior to treatment. 2 more questions came in, sorry. The sensitivity of PCR versus flow differs. So if you have both, which one do you rely on? Again, this was from the the ELN if you have both, and you have the way to track PCR for one of those 5 situations where our recommendation is PCR in the first instance for one of those 5 cases. The sensitivity of flow varies actually by patient and by clone of patient. We set a conservative threshold of 0.1% in the ELN guidance, but you're right in that PCR is absolutely more sensitive and arguably more reproducible. So our preference is if you have both, you should use PCR if there's one of those 5 mutations available in that patient. And finally, were the benefits shown from treating patients MRD positive pre and post transplant? What treatment? DLI, hypermethylating agents from Dr. Hung. So thank you for that question. Yeah, so there are trials of treatment. So the WILASA trial was a single-arm study of intervention on patients who are MRD positive post-transplant using azacitidine. There have been studies of DLI. The data I've just shown you is the only randomized evidence I'm aware of the benefit of intervention on MRD. But many of those trials are ongoing. As I said, there's many randomized trials being planned or currently starting of intervention on MRD pre and post transplant. So I think we're gonna generate that data over the coming years. And sorry, 2 final questions. What is the optimal depth for ingest in AML and MRD assessment? This hasn't been defined yet for our study. I just presented. We matched the ELN requirement of 1 in 1,000, so 0.1%. NGS in AML can actually go much deeper than that for some mutations, for example, NPM1 mutation or FLT3-ITD. But the prognostic benefit of that hasn't been firmly established. And so we think at least 1 in 1,000 is 0.1% is what's currently being used in research studies. But again, I don't think that's ready for clinical use yet. And final, what level of confidence is there in relation to the threshold of positivity according to AML type and the intensity of therapy from Dr. Zomas? Again, great question. And it really, it's making an analogy to the situation in other heme malignancies where actually there's a dose burden effect. So where in other situations more leukemia is worse than less leukemia. In AML that hasn't come out, and so down to the sensitivity of the 2 studies I showed you in JCO from 2017, down to a 1 in 1,000 threshold, it seemed like any detectable AML, whether it be 20% or whether it be 1 in 1,000, was associated with equally bad outcomes. Whether that'll change when we develop very highly sensitive tests, as we're starting to see in other hematology malignancies, is an open question. But for the testing that's currently being used, down to 1 in 1,000 sensitivity, there isn't great evidence on that. I think the one exception to that would be the core binding factor leukemias, which are a special case. I think most people would track the core binding factor leukemias and APL with qPCR alone. And I think there is disease-specific thresholds which came out of the MRC group and a few other the French CBF trial. And that's described in the ELN guidance, where by AML subtype, there's actually different thresholds. But grossly speaking, detectable leukemia below that CR threshold is bad news until you get to very low levels of residual disease. Okay, and we're out of time, and that looks like the last question. So I'll thank you all, and I'll thank the International Academy for Clinical Hematology, Professor Marty Nagler and Savani for arranging this. And my email address is on the screen. My research library at the NIH is dedicated to AML and MRD. So if you have any questions, I'm happy to talk. Please feel free to send me an email. Thanks very much to you all. Good night.